Thank you, Alika, and thank you, Kamea. Your sharing of the system change principles and the innovation concepts really resonated with me and also advanced my thinking and curiosity in terms of challenging some of the traditional paradigms. So thank you very much for that. I am Lisa Calder, and I am a settler of British, Polish, Scottish, and Ukrainian ancestry, and I reside on the lands of the Iroquois, St. Lawrence, Iroquois, and Huron-Wendat, which is land under Treaty 57. The Cmpa, the organization that I work for, those buildings reside on unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. I want to start by saying that I am here to learn, and I recognize that I have a lot to learn. And I approach this conversation with humility and a growth mindset. If I say anything that causes offense or hurt, please tell me, because that's not my intention. I also want to acknowledge what Alika just touched on, which really was that heartbreaking discovery of the bodies of the 250 children at the residential school in Kamloops. And I come here with a heavy heart, knowing that we have a long path towards reconciliation and healing. I thought I would just make a few remarks about the Cmpa, who we are and what we do. We are a national not-for-profit organization that represents over 100,000 doctors in Canada. And our work is to really focus on how we can enhance patient safety and also support doctors who experience complaints in hospital settings, clinic settings, through the regulatory bodies, and through the courts. We are a trusted voice for doctors, and we champion issues that we see will improve patient safety. I'm a newly appointed CEO to the Cmpa, and I have launched a new journey for us in terms of trying to look at ways that we can improve and enhance equity, diversity, and inclusion at our organization. And we have a clear focus as we develop our strategy on looking at anti-Indigenous racism as it's experienced by patients from our physician members and also by physicians who are Indigenous experiencing racism in a healthcare system. We're also looking at any racism that are experienced by our members from the services we provide at the Cmpa. I recognize we have inherent racist biases in the Cmpa structure, policies, and services, and we are open to examining them, addressing them, and striving towards improving cultural safety. Status quo is no longer an option at the Cmpa either, and we're committed to improving, and we know this will take ongoing commitment and time and having these kind of conversations, which I feel really privileged to be part of today. A few comments on data and patient safety. So I've had a career in patient safety research, which is its own science, and specifically I've worked on trying to understand better patient safety incidents that happen in emergency departments. And one thing I do know is it's really hard to solve a problem when you only have a piece of the puzzle. And so understanding the nature of these problems as part of our role at the Cmpa is gathering data and information to have a better sense of a piece of the puzzle in terms of the types of patient safety events that Canadians experience. Now, historically, patient safety science, when you go back 15, 20 years, focused on harm related to the healthcare system that was physical harm or injury. And at the time, the case was made that this was because it was quote unquote objective and measurable. Since then, that model was challenged, and we were asked, well, what about mental and emotional distress related to healthcare that was provided? Doesn't that count as a patient safety harm? And we've evolved our thinking to embrace that. And the key to that is also being open to hearing patient stories and qualitative data and information, not just counting incidents and looking at numbers. The next frontier, I think, is really looking at the harm related to racism as a patient safety issue and thinking about that more broadly. So measuring patient safety, as both Alika and Kamea have highlighted, is not easy. And traditionally, we've relied on voluntary incident reporting systems, much like the example that Alika described that he experienced and was asked to report into. Incident reporting in hospitals have been widely studied around the world, and while it is a standard, they are seriously flawed. And Kamea highlighted some, I think, really interesting challenges to incident reporting as they have been designed in the past. And I'll just add a few other observations that have been reported in the literature. And that is that they're often voluntary, but interestingly, if you make incident reporting systems mandatory, it doesn't enhance the quality of reporting. There's a lack of a closed loop. So if I, as an emergency doctor, report an incident and nothing happens, I'm not going to report another incident. And this is frequently the case with incident reporting systems. There's definitely an issue of signal versus noise, which means trying to pick out where are the opportunities to really make improvements out of all of the incidents that you're seeing reported. And it's widely known to underrepresent patient safety events. Also, traditional methods have relied on healthcare documentation, which often doesn't reflect key parts of the interactions which led to the event. And if we consider the case of Joyce Echaquan, if we did not have her video, would we have known what had happened to her? If we had looked at her health record, would it have revealed the racist language and biases that led to her death in the healthcare system? I don't think so. And yet that is traditionally what we have relied on. Direct observation is often held up as a preferred method for identifying patient safety events, but really hard to achieve. Video is starting to emerge. And so now increasingly operating rooms, emergency departments, and even labor delivery rooms are looking at the use of video. Lots of challenges to overcome there in terms of ensuring there's patient consent, privacy issues. And yet with all of that, there is opportunity also to identify language that's being used, microaggressions through the use of video capture. And this is starting to explode a bit in terms of a technology that's being used increasingly in healthcare settings. But at the end of the day, as Alika and Kamea both highlighted, what we really need is the story. And we need the story from both the patient and the healthcare team. And in piecing this together, we can better understand what patients' experiences are, what the healthcare providers' perceptions were, and the areas of the system that are causing harm. And Alika referred to the WHO numbers in terms of the frequency of harm. In Canada, the numbers reported are considered to be rare, but fully acknowledged that they're undercounted. And as Alika said, most likely much higher, especially amongst Indigenous communities in Canada. So a key theme in patient safety science is that patients who experience patient safety incidents want to know why it happened and prevent it from happening to someone else, which is what Alika said. And we need stories and data to better understand these events to prevent them from happening. And I think that the Safespace technology that Alika and Kamea are describing is a really exciting, different, innovative way to help remove some of the challenges that exist with our current ways of capturing data around patient safety. And the last thing I'll just comment on is what are we doing at our organization at the Cmpa? At the Cmpa, we have an advice phone line where hundreds of physicians call us every day, and these doctors tell us their worries and their stories, and they seek our advice on how to provide safer care and how to manage complaints. We get over 20,000 calls a year. And our data, though, not only include the doctor's stories, but also some clues. And in some cases, we get case narratives from patients that describe what they experienced. And in the past 5 years, we've started looking at this more broadly, not just focusing on what the doctor did, but looking at the role of the provider, the team, the system in contributing to the harm. We're actually the largest provider of education to enhance patient safety to doctors across Canada. And traditionally, we've relied on our own data as well as reported in the literature to drive that education, but we are actively seeking other sources of data and information to help inform that education. So our goal at the Cmpa really is to prevent harm from happening. So I want to thank you for your time today, and on behalf of the Cmpa, we really appreciate being invited to this conversation and look forward to ongoing and more conversation, as well as learning to continue to learn how we can improve the safety of care for Indigenous communities across Canada. Thank you.
Hi, Alika, Kamea, and Lisa for your presentation. Some of the comments from the chat, mind-blowing, so interesting, beneficial approach across many systems, so empowering and inspiring. I think they like it, people. So I just wanted to invite Leslie to share her perspective on implementing Safespace at the BC Association before we move to the questions. Leslie?
Oh, sure, sure. I've been avoiding the camera. I think I got spinach on my teeth. Never eat spinach for lunch when you're co-hosting a conference. We are deeply, deeply, deeply honored to be able to facilitate, the Safe Space app in our 25 friendship centers. And we are just getting it started right now. We're just piloting it. It is in the intention for this app to go national through the National Friendship Center movement as well, so right across the country. And so we're having some fun right now, collecting the information and seeing how people are responding to it. And Alika, the last time we checked, we had about 4,500 visits to the app. Is that about right?
Yeah, it's almost 5,000 now since we talked last.
Yeah. So, I mean, this is a huge honor for us, and it's a way to take some action and to take some control. And I think I've and others have pointed it out to you that the internal complaints process within the health authorities and the health systems is your input goes in, and then they spit out an answer for you, and there's no satisfaction for it, and there's no accountability, and you don't know, what's happened. Or if that was just a learning opportunity at the expense of your racism experience. So this is something that I really, this combined with the SANYAS, so there's some decolonizing anti-racism training. Now you know what to do. And now if you don't do what you know what to do, well, now we have a Safe Space app. So in some ways, we're taking some control back of the issue. And so we are so proud and humbled to be able to contribute to that. So thank you, Kamea and Alika. Thank you.
Wonderful. Thank you, Leslie. I just have a first question from the chat, and maybe I'll just throw it out to the three of you and you can decide who's best to answer. It's more of a reflective question. Where is the patient or client perspective in the health record?
So I can answer this a little bit. So I think among all the different medical specialties, mine's probably unique in that once I start to give you drugs, your perspective stops mattering. And that's pretty soon after you meet me, right? So we have a conversation for 5 minutes, then you're off to sleep to get your gallbladder removed, and then you wake up and you never see me again, right? And so I'll tell you that when we talk about patient perspectives, it's often the projected perspective of what the provider sees versus what the patient is actually trying to communicate. And, just going back to the trauma that happens as people go through the reporting process, this reminds me of what happened when I submitted the complaint about the news. Is there was another letter that was sent by the person who did the event, and in it, they changed what happened. They said this was my interpretation of events and more or less wrote me out of the story. And so from 2016 to actually just last month, when the report was published by the Alberta government, which kudos to them, they shared the entire report. And that was a very, very brave thing to do. So I think our health minister and our premier, although they don't get a lot of support a lot of times from Indigenous people, and in this case, they did do right and shared the information. I could actually see how I was written out of the story. And I always wondered, why did no one reach out to me to ask what had happened? And it's because someone else had documented in a place that was a source of truth what happened. And going back to what Kamea had presented about centralized systems, if you get good leaders who are empathetic and create space for those people who don't have power, centralized systems work really great. But in places where that doesn't happen, centralized systems can overwrite your truth. They can write you out of your own story. And so within patient records, that's really a place where you can be written out of your own story unless your provider chooses to provide that space for you. And the reality is there's a lot of providers who do, right? There's a lot of providers who actually do give the patient experience and say what patients are saying. I know I really try and do that within my practice. I try and use quotes when I talk about patient perspectives, because I think that's important when I'm handing off to colleagues, that they understand what patients are actually saying and they can expect and have context and other things. Especially when patients are upset, I often give reasons why it makes sense why they're upset. You know, that way when they get passed along through the system and they no longer see me, at least people have some context and can prepare themselves and understand where my thinking was at, right? But for the most part, within the way that we organize patient records right now, your truth is overwritten by my truth as a provider. And it depends on whether or not I include your truth or not.
And I would just add to that you know, as an emergency physician, it's the same issue, that there's definitely a provider lens to the patient story in terms of documentation. I think about other specialties, though, that do this better. I think in psychiatry and family medicine, there's often a more of an intention in the documentation to reflect the patient's words, what they're really trying to say, and you can get more of that narrative. But in a lot of other areas of medicine, it's a lot harder to pick out, and you definitely have the provider lens that's overlaying the story.
Thank you, Alika and Lisa. Kamea, did you have anything to add?
Well, I did, but it was on a different question. Is that okay?
Yeah, completely. Go for it.
Yeah, so there was a question in regards to a pseudonymous approach in terms of system learnings and how this would actually be useful in sort of an investigative uh, point of view. And I think it's important to understand which phase of the process that Safespace actually exists. The problem that we see is that this is actually pre-entering the system, right? And any good reporting system will give you a sense of what's going on, but the real problem becomes attribution. So I'll just give you a quick analogy and then we'll go back to the reporting issue. When you recommend a restaurant to friends, you actually don't get attributed the value for the work that you did for telling them to go to this restaurant and eating there. Who does? Well, it's usually going to be Google or Facebook, whatever search engine your friend uses to then go and check out that restaurant is going to get the value that you actually push them into. And so in a pseudonymous system, what it really unlocks is this ability to solve the attribution problem, which is actually a data sovereignty problem. We can actually trace back to the specific user who said what, and continue the conversation with them pseudonymously. And so when you think about investigating, it's actually very useful to have an immutable way to communicate with people that can't be censored. So that at a future date, if you did need to actually call on that individual to come forward, help solve this problem, provide even more evidence, a pseudonymous system would actually allow you to do that. An anonymous system wouldn't. And in a system where they were, charged to come forward and disclose their identity, again, it's just riddled with all those risks. So this kind of acts as sort of an in-between place where things can be figured out. Because as Alika said, most patients aren't coming forward with an understanding of how to navigate the system. And so they're already disadvantaged on day one. We're just trying to create that space prior to entering to there, where they can actually launch a formal complaint if that's what they choose to do, so that the system can get a heads up, so that the system doesn't have to deal with the highest risks at all times. They can actually learn ahead of time and anticipate these things coming forward and educate the patients. So I just wanted to make that distinction because I think it's really important that I'm not saying that pseudonymous systems solve the need for a justice system. What I am saying is that it does add to the data collection process, which is actually step one of figuring all of this out. And if you don't have a system that people trust, you just won't get the data. This isn't going anywhere anyway. And the last point I wanted to make was when the question was asked about, well, how does this help with investigating? Investigations imply resources to investigate. That's where we're also starting, because if resources aren't redirected to investigate a complaint, it just very simply doesn't happen. So unless you also solve for the collection of data problem, you're not likely to get as good investigations anyway. So the primary step is to strengthen the patient, steelman these complaints, prepare them to enter the system, and doing it in a way that respects their privacy until they choose that they want to go down this dangerous path.
Now, if I can just segue into another comment that I saw in the Q&A, just about the accountability aspects. I think the slide that Kamea shared when he talked about the bundling of all these things together in a centralized system, the person who collects, says what's true, is the jury, is the judge, is the person who decides what the punishment is. You know, this is really what we're unbundling, right? And so I'll underscore what Kamea said, where you have to look at where this is in the system. So Safespace is not the judge, right? The judge is still the system, because that's the way that legislation works. That's where the investigative resources are. But what we can provide is a way of unbundling these other things. We can make sure that your truth doesn't get overwritten. You know, we can make sure that when patterns get generated, that we have this collective awareness so people who have resources can make better choices on where to share things. You know, we do this in an intuitive way already. You know, when news broke last week about, you know, the unmarked graves at the Kamloops residential school, like you saw the collective consciousness of Canada just stop what it was doing, and suddenly no one was talking about COVID anymore. You know, no one was talking about politics in Alberta, where I lived. Everyone was focused on this problem. And this is what collective awareness allows us to do, is it allows us to have people share their truths, have it generated into patterns, and then have us naturally start to understand, you know, what's going on. We do this in a way that's not scalable right now. We ask our family and friends when we go to a doctor, what kind of experience am I going to have? You know, we ask ourselves when we have a surgical problem, who should I go for as a surgeon? Imagine if you can scale that across 300 people that you don't even know. You know, this is really what we're talking about when we talk about pseudonymous systems and kind of the technology that underlines what we hope to achieve with Safespace. But it's an unbundling. Safespace is not trying to become a centralized, all-in-one place that replaces the system. We're trying to unbundle in the places that make sense and to fill those roles that we know the system right now doesn't do a great job of because of these environments of low trust.
Great, hi for that answer. The next question is, I'm curious about upscaling and improving uptake of the Safespace app, and if people will still utilize the app if it is advertised within the health system, or does it once again become part of the system? I'm also curious about how the loop of the complaint gets closed.
So I'll maybe start this and then toss it off to Kamea, and I'd be really interested in what Lisa's opinion was in all of this. But when it comes to providing value back to the reporter, there's two things that we've heard over and over again through, you know, our customer research work with the executive directors of the BC Friendship Centers and other sites across Canada that we're working with, is that people want the harm to stop. They want to become aware of it. They want to be able to avoid it if they can. And if they can't avoid it, they want to know some strategies in order to mitigate the harm that they could expect to have. You know, so that sort of value is coming in the second half of the project. When we're opening up the mapping system, people are going to be able to see kind of where some of these things are happening in real time and start to add to it. As far as where people report, we talked about these cycles of truth, but the other side of it that we don't emphasize often is the betrayal, right? So you have a strong sense and relationship with someone where you feel that the relationship is strong, but then something happens that makes you feel betrayed. And this can be big or this could be small. If it's a weak relationship, you know, someone using the small word, the wrong word, that can create a feeling of betrayal, right? A strong relationship, you need a much bigger event to happen in order for that to occur. But with all organizations that kind of exist within these contexts where people report and trust, all of them can be part of the Safespace network. You know, so BC Friendship Centers cater to a demographic of patients that experience harm that are Indigenous. But what about Asian people who live in British Columbia? Black patients? You know, what about doctors and nurses? There's different groups that all have those trusts that might be different or the same as BC Friendship Centers, and so the idea of having the pseudonymous system and in the way that we're kind of creating the technology is providing an opportunity for people to go to places that they trust and always have that opportunity to choose where they trust. Maybe things will cycle and people won't trust one organization anymore, and someone who's been historically not trustworthy suddenly has a high degree of trust. Why put the burden on the patient to still work with the same organization when their feelings towards them have changed? And so that's a big underlying principle that Kamea shared earlier. Maybe Kamea, you could extend that if you have anything to add.
Yeah, that's a perfect explanation. At the core of all of this really comes down to protecting the user's identity, and how is that identity managed online. Because as soon as you can do that, just like Alika said, they now have the option to take their identity and connect to another organization's application because they have their trust right now. And so in a way, it kind of creates this beautiful system where now the patient is not trapped in reporting through a pathway that they no longer agree with. But you have to give them control of their identity and what they've said so that they can take that with them everywhere they go. And I think that's sort of at the root of this question. I don't I don't want to glaze over the concern of like, how do you close the loop and those kinds of things. But the problem we're trying to solve is really upstream from that. And if we don't get it right there, we're just going to keep muddling around at the level of actually trying to deal with it. You have to go upstream. The solutions are often upstream, but upstream is under-resourced. Upstream is incredibly diverse. I think of it, the difference between shareholder capitalism and stakeholder capitalism. Look, the world has just changed. It's no longer good enough for an organization or a business to do what's in the best interest of their investors. They also have to prove that what they do is good for the world. And I don't see this any different when you take a look at these systems and how they're designed. It might have been designed really good for the system to protect them and reduce risk and be thorough and really, really pound down on these people and make sure they're telling the truth. And that's good for the system, but it's not good for the world. It's not good for the patients who come with absolutely no power. There's this huge, huge gap of knowledge. They don't know how to navigate, and we're still expecting them to jump into the pool and help us figure out these problems. So to circle back to the original question, yes, it really comes down to letting the patients control their story, letting them control their identity, and letting them plug into the systems they currently trust and change and withdraw from that system if they don't trust them anymore.
Lisa?
Thank you, Nancy. I think, and I might have missed it in your presentation, Alika and Kamea, this time, but I seem to recall, Alika, you mentioning before, part of the opportunity, it sounds like, with Safespace is summarizing aggregate themes of what you're hearing. And if people can see themselves in that, that is a way of closing the loop, right? Where it still protects that patient's identity. They're not sort of like broadcast, and if that's what they want. But if they can see themselves in that and how that information is being shared and utilized, I think that is an effective way of closing the loop without necessarily having to do it with each individual reporter.
That's correct. And I think further to that, there was back to that CBC article that I shared in the presentation, that was also accompanied by an interview. And one of the most interesting things that sort of made me take pause was that the interviewer was asking point blank, right in the middle of this grief, well, what do you want to fix this? Like, what do you want to change? And I feel like the system kind of rushes to that question before the individuals can actually have a chance to breathe and think about what exactly do we want to change. And if you had asked residential school survivors literally 2 weeks ago, already their answers have changed because new information has come forward. And so in order to sustain this kind of reporting over a long period of time, we really believe that these principles need to be adhered to. Otherwise, you're just going to keep having to reinvent the system, every so often to try and reestablish trust. And then you end up just playing a PR game. And the truth is, PR in an internet world, you're much better off being transparent than you are trying to PR your way out of problems.
A part of this too that I think we all touched on was, sometimes patients don't want to be that person who's out there, going through the process. Some people just want to be a part of the story, and sometimes patients don't want to be a part of the championing it at all. Sometimes they want champions like Leslie to stand up and say, hey, look, this is what's happening. This is what they're telling me we need to do in order to move forward. And I think the existing system, and what I tried to explain in that one slide earlier, was that, the burden is always on the shoulders of who it happened to or who witnessed the event to make system change occur. And in the best systems, one's not necessarily in health, but elsewhere where you have great cultures where people are willing to, give their heart and soul to organizations because they feel like they get their heart and soul back as a result. These are the kinds of systems that they live in, ones where they don't have to put themselves out there. And so you're going to get a mix of patients. You'll get patients who are willing to risk it all in order to move things forward. They have a place within this. You're going to have patients who just want to share their experience and then not have anything to do with it again. Those people will have parts in this experience. And for those organizations that want to champion those persons, absolutely there's a place for it. And this is why BC Friendship Centers was so important to the project and why they've been so important so far.
Thank you. The next question is, can you speak to much policy requiring identifying information and consent prior to investigations?
Yeah, I think I can just add just a few lines on this. I think this is one of the great beauties of distributed technologies, is that there's actually a balance. So I'll just bring it back to Bitcoin for a second. I'm not sure if any of you are familiar with it, but one of the main narratives around this idea of becoming your own bank and managing your own money, what I think people missed in all of that is that it's actually hard to be a bank. It's actually hard to secure and protect your money at all times. And in the same way, when you move towards a distributed technology to apply to this problem, don't ever think for a second that this makes the patient's lives easier. They also have increased responsibility in solving the problem. But it's the fact that you created a way for them to do that. That's what makes it better. And so when I think about how this actually gets implemented with privacy legislation and all of that, that's another advantage to pseudonymous systems, is you tend to fly under the radar because there's really nobody to offend, because you don't know who these people are yet. And so at the time, you're really just learning from the collective intelligence versus diving directly into the person, their credibility, their story, witnesses. You're giving it a chance, again, to breathe and materialize. And this is why, if you think about some of the greatest inventions of our time, it needed time to reach escape velocity. Because if it got shut down too quick, it would have never really made it. And in the same way, I think about patient stories that way. A patient may come forward with an assertion. You need to give it time to see this materialize, because some of these stories are being validated. And if they would have been shut down when they first came in, the trust is lost forever. You'll never get that patient back. They'll never speak with you again. And you do that over a long enough period of time, and pretty soon everyone goes silent on you, and you find out what you need to know on Facebook. And that's a really tough place to navigate as well.
Just to talk about the informed consent and other things about sharing your stories too, because we create anonymous narratives and we focus on patterns, we actually don't focus on incidences and targeting individual people. If you talk about racism that you experience in a clinic, that's very different than saying, I went to see Dr. So-and-so on Wednesday to have him look at my knee, right? One story, it's a high likelihood that you could probably figure out who you are. The other story is that you generally know that there's a problem, but it's going to be fairly difficult to figure out who exactly was a part of those stories. And so once again, when we talk about unbundling and bundling, there's different levels of information that are known to people that you trust across the system. And without getting into too much technical detail, what's important to know is that the public information that gets shared is shared in a way that protects your identity. And protecting your identity isn't just about taking away, you're identifying information. It's also about going to a pattern that covers like a pattern of care versus a specific event. And so when you look at informed consent and, compliance with health information acts and other things, because we don't actually collect data, because we don't ask people their names, their contact information, all those other things, but we use different ways to identify whether or not events were more likely or less likely to have happened. We actually eliminate that part of it. When someone shares their story and they don't have their name attached, the consent that goes along with it is supposed to protect you in case your name gets out there. It's actually to protect us, to tell you the truth. When you give us consent with your name, what you're saying is, if your name comes out, I will not hold you legally liable. So why not just eliminate the risk to you? Which I think is really the point of most systems that are designed around patients. And so consent it does not hold the same sort of meaning within our reporting system, because we don't create the same sort of risk that you need to give us a release for in case it harms you. We try and make sure that you just don't get harmed in the first place.
Right. Thank you. The patient quality care offices in BC have made commitments to change in relation to safer and more accessible approaches. What might you recommend to these offices, and how can Safespace contribute to this work?
Maybe I'll turn it over to Lisa first, and then we can jump into this question too.
So I think I probably need to understand a little bit more about the patient quality care offices in BC, but what you've and the work that no doubt you have done so far. I think one of the challenges that we have noticed in any organization that's working in patient safety and quality improvement is trying to identify areas to focus, because there's so much you can work on, and it can be a little bit overwhelming as you start to like uncover the data and the themes, and then you're like, well, where do we go next? And I think what's interesting about what Kamea is describing about Safespace is actually the validation piece, and the way Kamea described, one person comes forward, and as more and more people add to that story, it's a way of validation, and it elevates the priority of that particular issue. That, I think, is the challenge for a lot of organizations, is figuring out where are the highest priority areas that we need to focus that will actually make a difference. I see sometimes organizations spreading themselves too thin, trying to boil the ocean, really tough to do. And also thinking about, when you're prioritizing the areas you're going to work on, balancing some really key, crucial, complex work with quick wins, things that you're like, what, if we did that, we could make a big difference without needing to do a huge amount of effort. And that's how we could see this happening. So those, I think, would be some of the things that I would encourage you to think about if you haven't already.
Yeah, two roles for any group that wants to get involved in the network. The first is that you can report into the existing network that has been built with BC Friendship Centers. So anyone on that committee can share things that have happened. You don't have to be a firsthand experiencer of an event in order to share kind of what you've seen. So that's kind of the first thing. The second is that we're continuing to do a call out for insiders to be part of our validation network. And so we don't just take patterns, we also ask folks within hospitals who work within these settings, do you see this in your day-to-day work? And they're provided a level of anonymity as well. And so if there's anyone who sits on a committee or all those other things, and you're worried about the harm that might happen when you know that things are going on, we invite you to share some of your insight. And we will have a way for you to register and for us to have some idea about your expertise without you ever telling us who you are. And that's something that we're going to accelerate as we move into kind of the second phase. But that's a second rule that people within the healthcare system can share. I see lots of things in the hospital every day, and I've talked with leadership about, different issues, and I'm often told, well, that doesn't fit in my portfolio, or, well, we don't handle that, or if you put in that, then they might challenge you and say that you're being unprofessional for commenting on this because it's not within your scope. I mean, anesthesiologists, we get a sense for when surgeons are good or not, but I'm not a surgeon. I mean, I can't tell you what standard of practice is just by looking at you, even though I have a sense, right? And so that stops me from commenting on, the experiences of care that I see day to day outside of my specific sandbox, because that's the way that the system's built. So This gives people within the health system who would otherwise be restricted in what they could comment on and share to have that opportunity. And I think the combination of those two types of participants within the network really give it a different opportunity to help to create this collaborative awareness about these patterns. And I'll underline just one more time, this isn't about submitting complaints that Safespace brings forward. It's about creating patterns so people know where to look for problems. And then if they move forward into the system, there's the opportunity to do that, bringing all of the data that we've collected and organized into there. But Safespace is not designed to be the jury and judge for what goes on. And we're pretty firm with that, because there's already people within the system that do this, and we don't want to replicate things that already exist. We want to make parts of the system that don't work for certain people or for everyone better, and this is why we stay within the area that we're in.
Okay, thank you. This next question has a few different parts to it, but I'm not sure that you can answer it, but it's been voted up to the top. So I'm going to ask you, can we talk about the accountability aspect of these reports of racism? Has anyone developed a framework or key in analyzing experiences of racism? Where do these experiences fall in a spectrum of harm? Who decides that? Who gets allocated to remedial training? What gets allocated to discipline? Where is the line when someone is determined to no longer be entitled to the privilege of working with people? Just because a person pays for their courses or does the time for their education, does that entitle them to work with people for the rest of their life, when in some cases people are no longer kind to patients after 10 years of service? Sure, if anyone has comments about that. Lisa?
Sure, I can start with a few thoughts. I think that the issue of spectrum of harm is a really interesting one and challenging one to tackle for sure. It's something that the patient safety field has spent a lot of time trying to work on. I'm not sure that we've come up with a great approach yet, because it's the kind of thing that you get a group of people in the room, and getting consensus on where something sits on the spectrum of harm is incredibly difficult. And I think, again, what Alika and Kamea are talking about is addressing that power and hierarchical difference there in terms of who determines it, because really that's the patient's story, and the patient is who's determining that this is harm. It doesn't really actually matter what the level is. This is an example of harm. The other issue about, and I can just speak to doctors in terms of allocation to remedial training and discipline. Doctors are regulated by the regulatory bodies, and those are colleges across the country. Also, doctors who practice in hospitals have to apply for privileges, and so hospitals have a responsibility to address if there are issues related to racism and behavior. These are all systemic structures which are imperfect and definitely have flaws in them. I think there's an interesting piece though around remediation and how you can determine when someone is quote unquote remediated, or are they in a place where their practice is actually improved. And in the past, to be completely honest, doctors have practiced in a vacuum where no one's actually telling them how they're doing. And so they don't get that feedback. Once you finish your residency, you're out there and that's it. That's starting to change. And I think that there's starting to develop some better mechanisms of accountability within organizations for doctors to realize that you need that ongoing feedback. You have a responsibility to listen to that feedback, respond, continuously aim to improve. But there are mechanisms of discipline through the regulatory bodies and through hospitals that, again, are imperfect, but that's currently the way the system is constructed.
There's a lot of models of harm. I know Lisa probably helped design some of these, but it could go anywhere from a temporary harm that was maybe like an annoyance to something that limited your ability to do your day-to-day activities, but then went away, to like things that become permanent partial disabilities, complete disabilities, or eventually death, right? And all of these stories, they run the full gambit of, all of these different types of experiences. When you're talking about policy and like these measurements, but then practical application of these things, that's where it gets to get a lot more messy within the system. You can have a medical leader, whether they're a doctor or administrator, decide that rumors are enough to launch an investigation. And then another one says, well, I need to have 20 patient complaints before I do anything about this. And it could be the exact same situation, but with two different people, right? And this goes back to things that we were talked about earlier today, where we talk about systems of power and how to navigate these things, because that's an important layer to all of this too, right? Like you have the rules and then you have the flexibility within the rules, the enforcement of the rules, and then the behavior on what the norms are that may or may not align with what your rules are. And so when I was sharing the systems transformation outline that we use as part of all of the principles that we use when designing this network, we identify what are the things that patients are saying matter right now, and that's a little bit different than the harm that might occur, right? The intensity of the harm might be different than how far the harm spreads, right? And so both of those are very important. And as we work with health systems and, Cheryl Ward and the PHSA, we've had good conversations with them and Leslie about these different things. Articulating exactly what that means is an important step to figuring this out, because the reality is, I don't think we ever have. No one's ever asked that question in that way. We instead ask, what are the rules, instead of the behavior around the rules, and the things that create pressure to change, the biases that underlie why people do things the way that they do, and then the operational impacts that happen if they change what they believe, right? And so in articulating these things, we'll create a more nuanced way of navigating change. I know for those who experience harm, and I've experienced, like, I've had incidences where my children were almost harmed due to racism. There was an experience with Kamea where he called me in the middle of the night because he ran into an incident as we were kind of building out this software. There's my own experience in reporting that I mentioned earlier. All of these things matter. The challenge is that the system needs to be filled with people that can do these jobs. It took 15 years for me to get trained. You can't just fire all the anesthesiologists who express racist tendencies or create harm, because we would then have no surgeries, right? And so how can you create an environment where people can become collaboratively aware? The information that's shared is enough to do something about it, but not too much to create unneeded harm, to trigger people changing their ways. And how do you create an environment where patients can share these things just on a repeated basis, so we always know kind of what's on patients' minds? At the end of the day, the fastest system change is always going to be the voluntary one. The most nuanced system change is always going to be where people come together and they learn about everyone's perspective and then make decisions towards shared outcomes. If you have litigation like you had with medical assisted dying, you have a system that's rolled out that, to tell you the truth, I don't think really covers what patients who need that service actually need in a lot of situations. It's because everyone was forced into this way of doing things, and one or two people decided what was going to happen. And so keeping all those things in mind, like this is kind of how we've created the network and the philosophies behind it. And going back to the information that we've gotten over the last few months, it sounds like patients, feel this too. They just want the harm to stop. And so if we can do that without affecting people or making them afraid that they're going to lose their license or other things, maybe that's a good enough win. Maybe stopping the harm is good enough for the majority of people. And then for those who need more, we can also support them to go through the complaint system to get the other things that they need, right?
Thank you. I'm going to ask this question, and then I'm going to ask everyone who's an attendee to go on and vote up the last question, because this will be the second last question. What kinds of experiences, what level of detail are being captured in the app, and how might it be shared to patient community, publicly viewable on the website? Also, as racism existing as a baseline, is the goal to address and target some of the worst systemic pieces?
So I'll share a little bit about this, and then I'll turn it over to Kamea for a more technical explanation. But you can think of your story in extreme transparency, where you know everything about everything. All right. And then as you start to filter away the detail, at what level do you have enough information that you can still do something meaningful with it? And then you cross a line where it now becomes meaningless, right? So if you look at the majority of reports that are published across the country, most of that data is meaningless. Saying 89% of patients within this section of this province experience racism, it doesn't help at all. Like, it doesn't split racism into like that severe harm, the lighter harm, communication versus like loss of limb. Like, those are very different things, right? Surgical or hospital based versus not hospital based. So there's a lot of information that gets shared right now that's too little detail. Now, if you share too much detail, everyone just shuts down. Nobody wants to talk. If you just completely blast someone 100% of the time in the way that you talk with them, eventually they will just stop talking to you. Right. And so where is that detail in the middle where you can create that layer that everyone can share? We call it the common stack. Maybe you can expand on that, Kamea.
Yeah, sure. Well, just on a little further to deepen the conversation around this question, I think it's important to establish that truth exists in a distribution. So if our only option is to go and find the one person in the world who has the best judgment ever to decide on behalf of everybody what is right and wrong, it's clearly not the way the world is going, right? If you look at what's transpired over COVID, with the riots over the last couple of years, collective truth has completely overpowered the central narrative, and it has shifted it significantly in a short amount of time. And so the key is really getting as many voices in there as possible, to broaden that distribution of voices. And then from there, as Lisa picked up on, is that we can actually start to develop priorities around what to tackle first, because this is a moving target. If you reported a doctor over 100 years ago for not wearing gloves, people would laugh at you. You do it now, that's a serious offense. So you have to see this as a moving, progressive target that you need to continuously achieve the engagement of the population and give them the flexibility to interact with all the various options they have within the system. And it's that distribution of truth that really can ultimately lead to the kind of change that we're all looking for. But if we're just going to wait for somebody with perfect judgment to step in and say, I know how to judge this, well, you'll just continue to get what you have. And it's no longer going to work for, projecting into the future. That approach just isn't going to work anymore. And so even though ultimately there are going to need to be judges, there is going to be need some sort of authoritative distribution of resources to deal with a problem, all the work upstream can still be distributed up to that point. And that's what we're trying to say here, is that let's work on the upstream solutions and changes that need to be made so that by the time it gets to the final judgment, everyone's been heard, everyone's collaborated, everyone's had a voice. And that's currently not what's going on.
Now, when you talk about those extreme cases where there's significant harm that anyone would look at and say, yeah, that's really bad patient harm that needs to be acted on, that will come out as you start to work on that distributed truth, because you'll have things on the edges, right? Everybody knows wrong site surgery is something that's very, very serious. Everyone knows that denial of care leading to death, where someone is stopped from actually receiving care, is extremely serious. Right. And so those types of things will be flagged as we kind of work through it. Now, those cases, for the most part, tend to at least get into the public's consciousness. To some degree, those are reported. That's what people are used to reporting. People will get more used to reporting those things as they're given more safe options, like the Safespace network. But it's really creating that distributed truth that's going to have the huge impact for everyone. I often hear in patient safety presentations that, if you took bad doctors and made them good, you'd have a bigger impact than making good doctors amazing. And that's really the target, I think, of a lot of this work, is how do you get people who are doing bad enough care to create harm just to step back and make enough of a change where they become goodish, and if you make people goodish, you can eliminate a lot of the harm, and then maybe you can move past reporting harm to actually just creating relationships and providing people better skill training and all of these other things, right? But it's all kind of part of a stepwise approach to change, and Safespace deals with a certain part of it upstream.
Great, thank you. This will be the last question we have time for. I apologize to those attendees we couldn't get your questions. Is BC Association of Aboriginal Friendship Centers able to bridge to the app or provide third-party reports for people who don't have phones or aren't comfortable with tech?
So I think that's really a question for BC Friendship Centers, but I will say to Leslie, we will support creating opportunities for features that we know will increase utilization and that are patient-centered. So we will absolutely support anything in that vein.
Yes, thank you. And for sure, we've thought of that too. We are thinking about elders who don't want to download an app and start typing, and offering some phone-in processes for them.
Wonderful. Thank you, everyone, for your presentation and for the Q&A.